Welcome to Eye Contact. I'm Sean Henahan. We're talking with Dr. Soosan Jacob about subluxated lenses and cataract surgery. Welcome, Dr. Jacob.
Thanks, Sean.
This is a huge topic. How often do you encounter this in your daily practice?
Yeah, Sean, since we are in a tertiary center and an educational institution as well, we do encounter it quite frequently. I would say about 4 to 5 or 6 times a week, which is almost maybe even more than that, 1 to 2 cases per theater day.
So it's a daily occurrence.
Yeah.
In your EUROTIMES columns on this topic, you dedicated a lot of time to talking about the assessment stage. So maybe you could walk us through the planning and management phases of this.
Right. So it's really important. The preoperative assessment is as important as the surgery itself. So, to get your help, you get your plan in place, what you're going to do for this particular patient, because everything varies from case to case. So you kind of need to assess the patient on slit lamp, take the proper history, find out why the subluxation happened in the first place. What was the cause? Is it something like Marfan's, or was it because of high myopia, or was it a vitrectomized eye, or is there a history of trauma? And so many things which you would want to know about. And then you also look on the slit lamp for the degree of subluxation, which is you see in clock hours how many clock hours of zonules are not there. And another important thing at this point is when you seat the patient on the slit lamp and view, it's sometimes very misleading because it may seem to be a smaller subluxation than it actually is, and suddenly you find yourself surprised when the patient is lying down in front of you for surgery and you find that it's actually much more than you thought it was. So it's nice to also examine the patient in a lying down position in the preoperative assessment, just to know how much of subluxation there actually is, because then the cataract suddenly just moves downwards and then you know that it's more and you can plan accordingly. The other thing you need to see is also the density of cataract. So if it's a softer cataract, it's probably easier to manage. Harder cataracts are more difficult. And then you also look at associated ocular conditions. So for instance, is it associated with a small pupil as well? Then you know you're going to have added difficulties. Pseudoexfoliation, are there any endothelial problems? Or, is the retina all right? Because Marfan's, there might be retinal weakness, areas which you might want to treat even before surgery. So all these things make up a part of your pre-op assessment.
So you're going to be looking at some probably complicated techniques. For example, what's the role of the capsular tension ring?
Right. Capsular tension ring is actually key in subluxated cataract surgery, because you would want it, you would want to place it even in the smallest of subluxations. So let's say you have a subluxation of 1 to 3 clock hours. In that case, you just put in a capsular tension ring, and what it does is it expands the capsular fornix. So it makes the bag round again, and it redistributes the stress forces. So wherever there is, the zonules which are acting, it also gives the action of those zonules to the area where zonules are absent. In addition, it pulls out the posterior capsule. The posterior capsule is otherwise lax and floppy, and it's possible that floppy capsule could get caught in your, phaco probe or I8 probe or whatever. Since the posterior capsule is now stretched out, the chances of your accidentally grabbing the posterior capsule decreases.
So you can relax once you get that.
Yeah, well, you can never relax when you're doing a subluxated cataract, but it helps.
You were mentioning a different device.
Oh yeah. So this is we call it as the paperclip capsule stabilizer, and I designed it, and it's being marketed by Mocha. Actually, it's just been released commercially in this ESCRS. And what it does is, conventionally for subluxations that are larger than 3 clock hours, you would use some form of scleral fixation in the form of a Sioni ring or an Ahmed segment or whatever. But all of these devices that are currently available, they need to be sutured. So you need to have a suture, and it's actually, I would say it's almost similar to doing 2 surgeries when you're having to suture this device in place. That's tough. And then again, you go and do the subluxated cataract surgery, which is again tough. So you don't want to have 2 tough things to think about. So what this device does is, it works on a paperclip principle, and it has a haptic. So you exteriorize the haptic out through a sclerotomy that's made under a scleral flap, and the paperclip portion of it just clips onto the rhexis. And so you pull the bag into place, and then you tuck this haptic into the sclera, and it gives you very good centration of the bag. And in addition, you can adjust the centration easily, unlike a knot which once tied down is difficult to center anymore.
Now, this is one of the more dreaded complications for any cataract surgeon, particularly a trainee. So at what point do you think they should ask for help? When do they know they can't handle it anymore?
Right. So I think if a trainee is doing a subluxated cataract surgery, he would already be in the final parts of
Sure.
his training, so he would reasonably be confident about most steps. He still needs to, of course, take extra care, and if he's doing a subluxated, it's still always wise to keep your mentor or your trainer with you, because you don't know when problems are going to happen, and you also don't, and he also may not be, he or she may not be aware that something that he or she is going to do could end up in creating a larger dialysis. So whenever you have problems, let's say if it's a tough case, a brown cataract, that would be something that you wouldn't want to handle as your first case, along with the subluxation, or a small pupil, or additional diseases or comorbidities that the eye may have. Large subluxations are something that you don't want to do as your first case. And similarly, dangling cataracts, which are literally going down into the vitreous. So these are situations which you probably would avoid, and as also an extension of the dialysis if you're doing a small one. So these are things which, yes, you would want to ask help for.
That's good advice. In fact, you have done a 3-part series for EUROTIMES. This
Right.
topic is so complicated and involved, so I would suggest that anyone watching who wants to learn more can look at that and the videos you've done on YouTube as well.
Right.
Thank you so much for speaking with us.
Thank you, Sean. Thank you.
Thank you for joining us. For more information, please visit us at eurotimes.org.